It's an interesting topic. Whenever you take a urologist and you ask them to do a talk, regardless of where the conversation starts, it's going to end below the belt. So I feel a little bit guilty because I know what's to come on that images, and where I'm standing at the stage, I think it's never been shown on the screens before. But hey, we are here for an honorary purpose, and this is things the Lord have made, and He's made us absolutely wonderful. And the more I work and learn in medicine, the more I stand in awe of just how wonderfully we have been made. And hopefully, we're a small group, so we're going to keep it really interactive. I'm going to, some of my slides may here and there seem a bit technical, but don't worry about that. We're going to explain it nicely. But the idea is that we talk about a few topics that I think is really very, very common. Let me put it first there. And it's topics that's very rarely spoken about among men. Maybe just a quick tale from my last kind of informal encounter like this. I'm a Afrikaans boerseun, and as most Afrikaans boerseuns do, we love hunting. And we're a bunch of university friends and brothers that yearly get together, and we have a good manne weekend, men weekend, and we go hunting. And probably it's not so much about what you shoot, it's more about the communion that you have there along the fire. And last year we were up there, and it's all of the guys are more or less my age. We're around 45 in that vicinity. And obviously I'm the only, for some reason, the only medical guy among them. They're all in other fields, and of course, they know I'm a urologist. Sometimes the discussion always veers into that direction. And we had a nice joke, said, well, listen, guys, this is now time. It's time to get your prostates checked. You're at that age now. And obviously, there was a lot of jokes and can't we just do it this weekend, get it over with? And no. I think everybody go to your local urologist. And interesting, it was a lot of joking, a lot of jesting, some information given. And just a month later, one of my friends that was with us calls me up and says, listen, I followed your advice, and I've been diagnosed with prostate cancer at 45. So hopefully, luckily, caught very early, and he's got small children, and he's just, you've just that discussion probably saved my life. So it's something that we need to talk about. And you'll see that the second part of the talk, we'll talk about prostate cancer, the basics, and what you need to know about it. Then we're going to veer a little bit into the sexual health part of things. It's another passion of mine because I think it's such an important part of our relationships. And it's godly made. And it's one of the most beautiful things God has made. And therefore, it's crucial to understand because this is a major cause of unhappiness in relationships, and it's based and rooted in not understanding what's going on. So hopefully I can give some better understanding, so there's context to everything. And then we'll talk a little bit about just 1 or 2 slides on vasectomies, how that works. Some of you may have had it, some of you still wondering whether you should have it. And I'll give 1 or 2 slides just to explain it. And then I'm going to leave a lot of time for questions and answer. We're a small group. So at any time, please, during this is a more discussion than a lecture. So at any stage, if you've got a question, just stop me and I'll explain. All right, let's jump right into it. So let me introduce you to the prostate. Probably the most well-hidden organ in the human body. So which of these structures are the prostate? It's this little bugger right about there. Okay, so as you can see, it is very, very well hidden. It's on the back side here. So just to orientate you on this image, this is if I had to cut you through like this, and we look at you from the side, this is what you're seeing. So obviously this is your colon and your rectum. Okay, this is your bladder over here. And this is the urethral pipe, the P pipe that comes through, and it runs right bam smack through the prostate gland, which actually surrounds it. Those of you who still grew up with tops, you remember a top, you wind up the string and you throw it and it spins. Now a prostate very much looks like a top. And if you took a drill and you bore a hole right down the middle of the top, that's your prostate. And the hole down the middle is the urethra. That's why as the prostate starts enlarging with age, because in a male body there's only 3 things that never stops growing. It's your ears, your nose, and your prostate. And those 3 things will never stop growing. Yeah, well, at one stage you get married, and then the ego goes down again. So, so at the prostate will enlarge, and that's why a lot of men, 70% of men at age 70, will start developing weaker stream or problems with the urinary stream at one stage. Because as that prostate gets bigger, you can see that it actually will compress and it will close up that pipe that runs through the middle of it. All right. So what does the prostate do? And if it's just causing us problems in old age, why do we have it? Because you need it in your young age. The prostate plays a massive role in producing very important components of semen, which is obviously really important for fertility. It plays a role in making sure that ejaculate, the cum, as we talk about, comes out the front and it doesn't go back into the bladder. And it enlarges, it unfortunately enlarges with age, like we've just said. And contrary to popular belief, it doesn't really play a role in continence, meaning not leaking urine. So it doesn't really play a role in that. There's other mechanisms for that. So this is a very technical slide, but all I want to say in this slide is how big a problem is prostate cancer in Africa? The answer is massive, and we're completely underestimating it. Just with the census of 2022, it's now turned out that prostate cancer is the most common cancer under males. And even more alarming, it's the leading cause of cancerous death under black and colored males. The only reason it's second under white males, and just because skin cancer kills white men more than prostate cancer does. It's because we don't have the melanin. All right, so that's the only reason. And the problem in Africa is that we are underdiagnosing it. To give you an idea, at this stage, in the Western Cape, and we've got the best numbers in the public sector, if you get newly diagnosed with prostate cancer, about half of those men has already got disease that's non-curable, advanced. Half of them. That similar figure in Europe and America is only about 10%. So we are at 50. That similar figure in KZN is 75%. 75% of all men diagnosed now with prostate cancer, it's too late. So that is the problem that we're sitting with, and they are predicting that in the next 10 years, prostate cancer is just going to explode. And there's a lot of studies that are being done at the moment. We at Stellenbosch are doing some of them, is looking at why this is. Why does prostate cancer in South Africa and in Africa look different to prostate cancer? And there's a lot of evidence that it's got to do with our genes, especially the genes that is associated with black African men. The cancer genes there, specific to prostate cancer, looks like it's a much more aggressive type of disease. So we are moving towards trying to find and trying to diagnose prostate cancer really much earlier in this country. So that's why this is so relevant. So who is at risk of developing prostate cancer? So there's a few things. Age. So prostate cancer age, the older you get, the bigger your chance of prostate cancer is. They speculate that if a man wants to get to 130 years of age, so they say the first person that's going to get up to age of 150 has already been born. No, they say the first person that's going to get to age has already been born. But it's probably not a man, because if you want to get to 130, any person that's going to, man that's going to get to 130 will probably need to beat prostate cancer during that period. Because if you get to about an age of 100, there's a more than 90% chance you've got underlying prostate cancer. Okay? So age is probably your most pertinent risk factor. Then, black ethnicity. So if you've got a majority of black ethnicity genes in you, then you're not more likely to get prostate cancer, but you are at risk to develop a more aggressive form of prostate cancer. All right, so that is where it comes. And then family history. So what is family history? Did I have an uncle twice removed? No. Family history, I'm referring to your brothers and to your father. If your brother or your father developed prostate cancer at a fairly young age, meaning at below the age of 65, then you are at a more of a risk of developing prostate cancer than what the general population of men who didn't have family members. So there's a very, very important link between that. Yes? Just like preemptively remove it before we get to that. So I'm going to, it's a very, very good question. Unfortunately, if removal with a prostate didn't come with a lot of side effects other than just that, it would have probably been an option. But it's quite a significant operation, and I've got some slides that I will show you. So it's not something that we routinely can do for healthy men, just because the risks involved with it doesn't justify removing it without there being cancer. It's not like in females where we do mastectomies to preempt someone that's got a high chance of developing breast cancer. They sometimes remove the breasts and put implants in, and that's significantly less problems that goes with it. Because if we remove the prostate entirety, there's a big chance it goes with erectile dysfunction. A very big chance. So there's a lot of, and that's a major concern. And the operation is quite big, but we'll show you. All right. Also, do not forget that the same gene that is causing familial or genetic breast cancer in females is also associated with aggressive prostate cancer in men. So it's not only if your dad, if your mom or your sister had developed breast cancer at a young age, it's also a risk factor. Right. So this is it's a very complex slide, but prostate cancer is not a very simple matter. I think most of you's experience with cancer is that of a disease that, sometimes you hear the diagnosis and, a year later, it's funeral. It's a lot of your experiences with cancer, lung cancer, other types of organ cancer is that kind of experience. The one thing about prostate cancer is that it is very, very unique in the cancer setting. And the two things that make it unique is that it's a very slow-growing cancer. It takes years for the cancer to develop, and even if the cancer is there, for it to progress. So even if we diagnose someone with a really advanced prostate cancer, with management options, we can give them 5 years of good quality life, So prostate, with other cancers that spread, it's months, or maybe, if you're lucky, a year or two. Prostate cancer is a bit different. Not all prostate cancers, and this is the controversial part, not all prostate cancers will kill you. Now you see how complicated it gets. Not all prostate cancers will kill you. And that's why you'll see now we take prostate cancer when we make the diagnosis, and we put you into a risk category of what is the risk that this disease will kill you. There's a lot of people who will die with prostate cancer, not because of it. Okay, so when we think about diagnosing and treating, those are two when we look at your life expectancy, that becomes a really important consideration when talking about treatment. So there is even a concept of over-treatment of prostate cancer in this setting, because if you're going to treat someone who most likely is not going to die from this disease, and you cause him problems because of this treatment, you've done this unnecessarily, and we call this over-treatment. So it's a very fine balance, and that's what we aim towards. So how is the diagnosis made? So there's two things that I would like to just emphasize. You've maybe heard the term of screening. We screen for a disease. What does that mean? Screening is similar to us having a talk here where it's a patient or someone that is at risk of developing a disease. So let's say you're over 50 and you are or you're a black African male over 45, and you've got a risk of developing the disease, but you have no symptoms. You have absolutely no symptoms. You've just heard from a talk you have to get yourself tested, or your wife is dragging you to the doctor, or one of those things. Then we talk about that as being screened for the disease. The moment you go to your doctor or urologist and you're having symptoms, like you're struggling to pee, or you're peeing blood, or you're having severe pains and constitutional symptoms with that, then it's not screening anymore. Then we're trying to find a diagnosis. Okay, so it's important to make that differentiation. That's why we separated those 2 points. First for screening patients, and we'll talk now about screening patients, and then if you've got patients with urinary symptoms, what should we do first? The first 2 things that's being done by your doctor is a blood test called the PSA test. And the PSA test is a test that we look for signs, or it gives us a clue that there may be a problem with your prostate. All right. It's not very specific. It's not going to make the diagnosis. It's a warning light that starts to flicker that says, go investigate. And then what also helps is a rectal examination. And why the rectal examination? Because that's what keeps most of men out of a consultation room. The reason is, if you look at this picture up here, because of the close proximity of the prostate to the rectum, we are able to actually feel the prostate, and not the entire prostate, but we can feel the back part of the prostate with a rectal examination. And what we're looking for is little nodules, little knoppies, bumps that may indicate that there is something that needs to be taken. This test on its own is not very good, but if you combine it with the blood test, it becomes much more significant. It is not the be-all and the end-all. If you do not have symptoms, our new guidelines that we've written for general practitioners regarding screening for prostate cancer, we've actually said you can leave out the rectal examination because it doesn't add that much value. Where it is of help is if you have symptoms. If you have symptoms, then the rectal examination is important. But if you're just getting screened, you can probably get by just with the blood test. Then after, if we get an abnormality on the blood test, or we've got an abnormality on the rectal examination, the next step is that we need to go do biopsies of that prostate. And this is done when we use, we sometimes do an MRI scan prior to doing the biopsies. We will put you through one of those scanners. Unfortunately, it's quite expensive. So in the government sector where I work, we don't routinely do it. But in private sector, most of the medical aids pay to get this MRI done. It just gives us an idea of where this prostate cancer is in the prostate, so that when we do the biopsies, we've got an idea of where to target it. And then we do the biopsies where we do it under a sonar guided, and we put a needle right into the lesion that we see, and we take some of that tissue so that our colleagues that is working in the laboratory can look at this tissue under a microscope and say there is cancer cells there or there is not. Because that is the only way we make the diagnosis. Okay, so all of that, the PSA and the blood test and the finger is just to alert us there's a problem, and then we move over to doing the biopsy, which will confirm the diagnosis and gives us an idea of what type of cancer this is, how aggressive it is. Remember what I said, not all men's going to die because of prostate cancer. So it helps us to put you into a risk stratifier. So who needs to be screened? Remember, we said screened is the guys without symptoms. Those are the ones listening to a talk like this that's never had to go to the doctor, but now it needs to be screened. So we do not screen men that doesn't have a 15-year life expectancy. Now, life expectancy is a really difficult thing because our life is in the hand of the Lord. We don't know when it's going to end. But we can look at your disease profile. We can look at your what we call all your other diseases, and you may have chronic diseases that's influencing your life. And we can get an idea of what is the chance of you getting to 10 or 15 years from now. If you are now 85, the chance of you having 15-year life expectancy, even if you're really healthy, is probably slim. But if you are 60 and you are otherwise healthy, you've got a really good chance of getting to 75. So that's how we make that decision. So if you've got a 15-year life expectancy, yes, you should be screened. And if you have an elevated risk for prostate cancer, when do you have an elevated risk? Any man over 50 has got a risk. Men over 45 that's got a significant family history of prostate cancer. Men of black African descent that's also over 45, you need to get yourself tested. And then if that mutations just mean if you have confirmed that you have one of these genetic diseases, like the women have that get early breast cancer, and you say your sister or someone's been diagnosed with this, you also had yourself tested and said you have one of these mutations, then you have to start testing already at age 40. Right. So what's the natural progression of prostate cancer? Meaning if we don't do anything, if we let prostate cancer just run its course, how does it look? Yes.
Before you go into the next stage, can frequent urination also be an indication that one needs to be tested?
Yes, definitely. Frequent urination, definitely you need to be tested. Even if it's not cancer, just what we call benign or non-cancerous enlargement of the prostate can also cause the symptoms, but it can also be cancerous enlargement. So you have to at least rule it out. So any form of urinary complaints, if you're starting urinating more, you're struggling with your stream, you have to stand there for a long time, you get up at night 5, 6 times, all of those things, if you're urinating blood, if you're having pain with urination, all those are kind of things. It's important symptoms. Right. So early stage of, sorry, if you've got early non-aggressive disease of prostate cancer, you're diagnosed with prostate cancer, and you've got what we call early disease, there's a 90% chance that you're going to live up to 10 years without us doing much. So that's good news. That's not like most of other cancers. Even advanced tumors, if I say advanced tumors, advanced cancer that's spread, cancer is very similar to weed in the garden. No. If you see a weed plant coming up there, you have to remove it before it's shot all its seed out, because the moment it's shot all its seed out, then it's difficult to contain. So the idea is you always want to find cancer while it's still confined to the specific organ, and then remove it entirely or kill it entirely at that point before it spreads to other parts. Because the moment it spreads to other parts, it's really difficult to cure. All we can do then is contain. Similar to your garden, you can contain it. It's always going to come up. You have to contain it. All right. But even advanced tumors, we can contain very well by removing the hormone testosterone from the body. Now, testosterone, the hormone that's being produced by your testes, that makes you strong and makes you a lot of the aspects that's associated with being a man, unfortunately, that is also the hormone that is the food for prostate cancer. Right, so when we have advanced forms of prostate cancer, one of the treatments to suppress this cancer is to remove its food, which is testosterone. Okay. And unfortunately, that also brings some side effects. So you never have there's always a bit of a give and a take when you manage cancer.
Peter, can I just ask?
Sure.
Is the prostate to men what the uterus is to women? And is the, and so obviously uterine cancer is very sensitive to estrogen. Does estrogen play a role as much in prostate cancer, the estrogen-testosterone ratio?
Yeah, it's a good question. There is a bit of a link. You'll see in the prostate, there's a little bump. I'll show you next time in theater. There's a little bump that's actually the embryological remnant of the uterus in a male. But so estrogen, in the olden days, we used to give estrogen as a form of suppressing testosterone. Because if you give estrogen to a male, estrogen is the female hormone. If you give that to a male, it will suppress testosterone production. But we have found more, that was done like 30 years ago, but we now have more more advanced forms of treatment that's more effective than estrogen. Estrogen comes with a lot of side effects in men. So estrogen, we sometimes use it when we run out of all drugs in public sector and we've got nothing else to give, we'll give estrogen. But then it's more not regarding receptors, it's actually by blocking testosterone.
But it doesn't drive does it drive the
No.
prostate cancer process?
No, estrogen, no.
Okay.
Right. So the most important part here is that we then, after we've made the diagnosis of prostate cancer, we put you in one of three categories. You're either low risk, intermediate risk, or high risk. Risk of what? Risk of dying from the disease. Okay. So if we put you in a low risk, there's a good chance we don't have to do much. We just need to observe and survey you, meaning that you will be for regular checkups at your urologist, usually initially on a 4 or 3 monthly basis, and then later on we can see you every 6 months, and we just monitor the disease. We check your PSA levels, we do an MRI scan every year and a half, and we may repeat the prostate biopsies in a year and a half or 2 years' time, actively surveying you for signs that this is becoming more aggressive. Okay. So then the nice thing about this, we don't have to do much. We just watch you. And if there is signs that this disease becomes more aggressive, then we'll treat. Okay. But what we've seen is that intermediate or high risk disease men, we try and treat them actively because we know the risk of progressing and the risk of this disease killing you is significant. So what is the fact is when we have to decide on treatment for you, there's a lot of factors that we have to decide on. And that's always, I've got a very open mind to write all kinds of treatment and things like that. The only thing that sometimes, makes me upset about, people on the radio advertising all kinds of natural treatments and all kinds of things, is that they are not taking anything into consideration. They think that this little herbal plant they're going to give to everybody is going to have the same effect. Out of this, you can see the amount of thought and the amount of individualization that we actually go into deciding what the right treatment for you is. And prostate cancer we absolutely treat you according to your specific disease. It's not all treatment fits one. And we treat you very, very specifically towards the type of disease you have. I mean, a lot of these guys don't even ask what type of prostate cancer you have. They just give you this will cure you. Then if it's too good to be true, it's usually too good to be true. No. If it sounds too good to be true, it is usually too good to be true. All right. Now I've got a lot of patients, and I can tell you stories of patients that's come to me, and the moment we make the diagnosis, we go through the whole process and said, listen, thank you very much, Dr. Spies. Thank you for all the information, but I'm going to try some alternative treatments, and my Bible study group's going to pray for me, and I trust that I will be healed. Wonderful. And I'll tell them, look, I'm also a Christian. I believe I've got a relationship with the Lord. But Jerne, don't be stupid. If the Lord, you don't have the right to prescribe to the Lord how He needs to cure you. You don't have that right. I said, Lord, I want to be cured. But you better cure me in a supernatural way. I want to wake up the next morning and be cured. That's how I want to be cured. And I'll tell you, but I've sent people on your way to help you, to cure you. But you decide, no, I want to be cured this way. Thank you, Lord, but I will wait until you cure me the way I want to be cured. Do you understand the amount of... I look at that people and I don't see faith. I see arrogance. You are falsely believing that you will be cured. The Lord will cure in the way you want to be cured. Sorry, that is my Sunday sermon for today. I have church on Sunday. I'm missing my church now, and that's why I have to preach to this morning. All right. So we look at a few factors when we decide on what treatment to give you. We look at your life expectancy, like we've said. If you have problems with your kidneys and heart, and the chances of your heart and your kidneys killing you in 5 or 6 years' time, I'm not going to treat your prostate cancer because you're not going to die from prostate cancer. I will not treat you prostate cancer. I will monitor it, make sure you don't have symptoms, but I'm not going to try and cure your prostate cancer. All right, so you have to have a life expectancy of at least 10 years before I'm going to try and cure your prostate cancer. Because otherwise, I'm giving you treatment that's not going to influence the outcome. Then the next thing that we need to know, this cancer, is it confined to your prostate or is it maybe spread elsewhere? And for that, we sometimes, so after we've made the diagnosis, we'll send for scans. It's all kinds of different scans that tell us this cancer is confined to the prostate, or there may be deposits of this cancer in other places. Then we will do, as I showed you, we will stratify. If this cancer is confined to the prostate, we'll then say, what is the risk of this cancer spreading? Low, intermediate, or high? And then we will take into consideration your preferences. We will give you more than one treatment option that is suitable for you, and you can make that decision based on that. We look at sometimes the size of the prostate. That may play a role. Previous operations that you may have play a role. If you're very fat or very thin, that may play a role in your treatment. It's always more difficult to operate a very fat patient. So there's a motivation to stay thin. And if you've had any previous treatment, that will influence your management. Now, what is the... Oh, thank you very much. Appreciate that. Now, again, there's a lot of things that you don't necessarily need to know. I just put the slide up. We've got two main curative options of treatment. If we decide you've got a cancer that's confined to your prostate, and you are at risk of dying from this thing if we don't do anything, then we'll give you one of 3 or 4 options. Thank you. And that options is usually either we have to remove the prostate with surgery, and the surgery's got different ways that we can perform the same procedure, and they've got their pros and their cons that we're not going to get into now. I'm going to just show you 1 or 2 things about robotic surgery, because everybody hears about robotic surgery, and Ellen is just so fed up now with robotic surgery being peppered. No, they're starting the robotic surgery. Vergelegen hospitals now gotten a robot. They've eventually caught up with Tygerberg Hospital. We've been having a robot for 3 years. And so we are starting, I think we're doing the first procedure on the 27th of May here at Vergelegen. So I'll show you just a quick, just for interest sake, those that like gadgets. We're all men, we like gadgets. So I'll show you what I play with. And then the other option is to give radiation, where we don't operate, but we actually give radiation to the prostate to kill the prostate cancer cells. And there's different ways of administering this radiation as well. And then, as we said, the other option is active surveillance, doing nothing. But doing nothing in a way of observing you and doing something when there is signs that this cancer is becoming more aggressive. Okay, so those are all the curative treatment options. And then if the cancer is spread out of the prostate when we diagnose you, then we give you treatment that we control the disease. It's called palliative, but in a sense, what it is to try and control the disease, to limit or to extend the period that you can spend with your family in healthy. And in a lot of instances, we can extend this period of up to 10, 12 years. And the cornerstone of that is removing testosterone from the body, and we call that hormonal treatment. Okay, and this can be done in a few different ways. The cheapest and the fastest way is unfortunately removing the 2 testes. Small procedure, remove the 2 to the amakanda. Kulula amakanda. All right, so we take out the testes. That is the cheapest and easiest way of doing it, but luckily we have more humane ways of doing this. I'm still trying to convince my financiers at Tygerberg Hospital to stop taking out testes and give them drugs. But the drugs are much more expensive. That's why they don't want to spend the money. But anyway, so the chemical castration is injections that we give that's got similar effects. So you keep your testes, but we give injections that suppress the testosterone in your body. So that is the way. And then if you have symptoms and disease and spread, then we can manage it and manage your pain and manage all of those things with things like chemotherapy and targeted radiotherapy to the areas that is painful. Right, so this is just robotic surgery. This is this is actually my photos that I took at Tygerberg. So it is keyhole surgery that we do, meaning we make small incisions and then we insert instruments that is connected to these robotic arms over here. And I control these robotic arms by sitting at a console just next to the machine. And I sit and I control the arms. When I look through that, I've got three-dimensional vision, which is very nice. I don't know if you've ever watched these 3D movies that you put the glasses on and everything looks 3D. Now, very similar to that, I've got 3D vision when I look through that, which makes the operation much more effective. I've got 10 times magnification, so it's like looking through binoculars at small tissue vessels. I can see very accurately and work very precisely. And the advantage to this is that compared to the standard way of doing this, when you have to cut and open everything, then you stay in hospital for 4 or 5 days, and this one you stay in the hospital for 1 or 2 nights, and then you go home, and you are very, you're up and going. So this is also just a little bit of I made a little quick video to show you how that little arms work. So we're working down there in the prostate, and you can see how that little arms, that little scissor and things, I can control it. It moves in all kind of different fashions. And this is us now removing the prostate, the last part where we're actually removing the prostate from the bottom. And you can see we move it like little arms in there that we operate with. So we can work in it's a very confined space down there deep in the pelvis. And these instruments allow us to work there at a very, very small. So you see there's not a lot of bleeding. There's a little bit of blood, drops of blood here and there. But we can work very, very effectively when we do this. Right. Any questions on prostate cancer? Yes.
Oh, thank you very much.
Okay, just before we start today, asking questions, we are busy recording. So we won't show your face.
No problem.
And we won't show your face, but we want to record this thing because this is once.
Yes, definitely.
Lifetime kind of a thing, if you don't mind.
Yeah. I always had a friend that told me you've got a face for radio, so I appreciate if you don't.
Thank you.
Not a face for TV, a face for radio. Yes.
Thank you very much for the information. I just want to find out the relationship between the hormone that you talked about, testosterone. You are saying if it is suppressed, what does it have to do with the cancer and the prostate?
Yes, so the testosterone, thank you, it's a very good question. So on these, the one thing that we know is testosterone does not cause prostate cancer. That is being investigated. It's not that testosterone, it's an interesting relationship. The testosterone does not cause the prostate cancer, but once the prostate cancer cells are there, they start feeding off testosterone. So these cells, they have, the testosterone hormone has got little, the cancer cells got little messenger receptors on them, which the testosterone binds to, and that activates its growth. So the testosterone is something that activates growth in the prostate cancer cell. So the moment you remove that testosterone, that cancer cell is not stimulated to grow, and you can suppress it. Unfortunately, in a lot of cases along the line, sometimes it's 3 years, sometimes it's 4 years, sometimes it's a bit earlier, the cancer starts finding a way to grow without testosterone. And we talk about the cancer then becoming resistant, castrate resistant, or resistant to hormone. And then we have other forms of treatment that we then give. So, but for the initial prostate cancer, for at least 2 to 3 years, you can suppress it by removing testosterone, that is its primary food. I hope that answers more or less your
Follow-up question, but will I be able to erect without
Okay,
testosterone?
we're going to talk about that now. All right. I'm going to answer that question for you now. Yes. Oh, sure. Alan.
So we had all of these things about the negative of having prostate cancer. Is there any pros in terms of diet-wise that we can take in terms of to keep our prostate
How
healthy?
to prevent prostate cancer?
Yeah.
The short answer is unfortunately no. We have not found. There's a lot of people who's going to tell you you have to eat this and you have to eat that. But if you look at the large research and the research that's been done that we give a lot of weight to, they've not been able to prove a specific dietary cause or a dietary thing that is linked to prostate cancer. So at this stage, there's not much that you can eat or drink that will prevent it. But what we do know is that obesity plays a little bit of a role. We've seen that obesity, men that's overweight, there's a link that there might be a chance for having more aggressive prostate cancer. We're not sure yet exactly why. But so moderation, I always tell, a balanced diet is probably the best thing that you can have. If you like something too much, anything too much is not good. So one needs a little bit of everything. But the short answer is unfortunately no. We don't have any specific dietary things that we can pinpoint and say that thing. You know, I know, for example, when it comes to gastric cancers and cancers in the stomach and things, there's a lot of things that they've associated with diet. Prostate cancer, no. Okay. Yeah.
Question. Is there a correlation between a vasectomy and prostate cancer?
Good question. No, there isn't. And that has actually been studied quite extensively. So no, there is no link between it. The interesting part is, and I'll show you now the anatomy, the testis and the prostate's got very little to do with each other. The testis and the penis has got very little to do with each other. They don't even share a blood supply. They don't share anything. The testis has got more in common with the kidney than it's got with those two organs. So it's interesting. Very few people know it. The testis actually, when you're a fetus, the testis develops up here at the kidney, and then it descends with its blood supply, its lymph drainage, its everything is actually right next to the kidneys, and then it develops this little cord that it descends with into that position. And the only reason your testis is sitting outside of your body and not like the females inside the body is because of temperature. Because sperm production needs to take place at a temperature that's slightly lower than your body's temperature. So the testis needs to sit outside of the body for you to be able to produce sperm. That's how wonderfully the Lord has made you. So it needs to sit there in a place where it can be a little bit cooler than what's going on in the inside of the body. And that is why and temperature must be just right. So you'll see that if you've got a warm water bottle or you put something on there, you'll suddenly see that the testis hangs lower. The scrotum kind of sensitive, everything hangs lower. But when it's cold, it pulled up. You can't find, it's up here. And that's how the body regulates it, because if it's really cold, it pulls the testis closer to the body. When it's warm, it lets it hang out loose so it can get some air. All right, and cool down. So, again, we've been wonderfully engineered. Wonderfully engineered.
Amen.
Just one further question. Are there two types of PSAs that can be taken?
The PSA, no, there's one PSA, but we can look at subcomponents. We call the free to total ratio. So they call about free PSA and total PSA. And we look at sometimes when you've got a borderline PSA that may be slightly large, slightly high, we look at subcomponents of this PSA and look at their ratios to help us make a decision. So no, we do one PSA, but we can do a further test to look at subcomponents of it, but it's very technical. And it's not even for general practitioners to interpret. I usually say let the urologist interpret that, because it's got quite complicated. But it's something that we use as an adjunct to kind of increase the specificity of PSA as a testing method.
Thank you for the information. What's the best? Okay. intervals to check your
Good
prostate?
question.
And maybe a recommended age?
Yes. So if you're black, you need to start already at 45. That's where you have to have your first PSA done. Now, it all depends on that first PSA. If that first PSA is low, because we've got certain values that we use for every age group. And if your PSA is low, below where it should be for your age group, you can have your next test when you're 50 or in your 50s. Okay. From age 50, we say every 2 years. Okay. So from 50, every 2 years, you can have your PSA tested. All right. And usually up to the age of 70. We don't really actually do that regularly. If you're not symptoms, if you don't have symptoms, then we don't do PSAs after 70 because we said, listen, life expectancy, 15 years. But if you develop symptoms, it's a different story. Then screening principles does not apply. Then we need to go find the diagnosis for your symptoms. And then we'll do regardless if you're 80 or 85 and you've got symptoms, we'll do a PSA. All right. But if you don't have symptoms, then we usually stop at 70. And we'll do a PSA if you develop symptoms later again. Good. Right, we're going to, at the end, do more questions. So if you think about anything else that you want to ask, we'll jump right into it. Okay, so let's talk about male erectile dysfunction. And that's just the big name for when you have a floppy penis, when things are not getting up, when the salute is not what it's supposed to be. All right. And I always say this is to me, I don't know if you all know who Leonardo da Vinci was, but Leonardo da Vinci was a famous scientist in the 15th century. He developed the most things that we know. Interestingly enough, that robot that we use is also known as the Da Vinci because it's based on robotic drawings that he made in the 15th century already. Of pulleys and things. He developed a helicopter in 1452. He drew sketches of what he thought. He looked at nature and he made a lot of observations, and then he would say, how can I apply this? And he did, except for being an engineer, he even dissected cadavers because he wanted to know more about the human body. And he made this comment back in the 1400s, which is still true today. He said, the penis does not obey the order of its master, who tries to erect or shrink it at will. Instead, the penis erects freely while its master is asleep. The penis must be said to have a mind in its own by any stretch of the imagination. So this was an observation 500 years ago, and I think many, many ages. So maybe after this talk, you'll understand why these things happen and what the function of it is. So I think I always tell this story because to the medical students, I train them on how to be doctors at Stellenbosch University. And one of the things that I always tell them when we talk about erectile dysfunction, and when you do a consultation with a patient of erectile dysfunction, that you have to really ask the patient because patients will just come and say, I've got a problem with my erections. But you need to go into detail to find out what exactly the problem is. And one point like this is a general practitioner that sent us a patient. He sent us a patient to our erectile dysfunction clinic. And his referral letter just said, thank you for helping Mr. Obanja. He's got problems with his erection. And when I was talking and speaking to this patient, I'm trying to figure out what's the problem. And he says, Doctor, I used to be able to do this 6 times a night, and now I can only do it 2 times a night. And I said, no, my friend. You've just gone from Superman to normal man. So you don't have any problems. So the problem is obviously in the eye of the beholder. But it's important, and the one thing that I realize a lot with erectile dysfunction and what it does with erectile dysfunction is because people do not speak about it, you don't know what is normal. You don't know what's normal for someone else. And it's got all of these things like penile length. I've got a lot of patients who come in there, who fly from the Emirates and from Saudi Arabia, come down to us. And so say, listen, I want a penis transplant because my penis is too small. And then I have to, and then this man has got a decent normal sized penis, but in his mind this is too small. So out of interest sake, and this is important, and I'm going to tell you, so what is the world average for a penis length? And I'm talking now about a flaccid penis that's being stretched and measured. And the world average is 11 centimeters. It's actually quite small, if you think about it. Most African men is going to look at us like, nah, boy, no, man, you call that thing, hey. But that's the world average. I know as white men, we bring the average down, but so it's important to understand what is normal and what is not. Now, sorry, this thing is running on its own here. So what is the definition that us as medical professionals use when we talk about erectile dysfunction? We say it's an inability to attain or to maintain a penile erection that is sufficient for sexual penetration or performance. Okay, so that's the definition. If you are struggling to attain an erection that is sufficient for you to have sexual intercourse with, that is erectile dysfunction. And you'll sometimes find that it is, in a lot of cases, sometimes it's intermittent. It can be present, and then it's fine. And then it's not, and then it's fine. Sometimes it's gradually worsening over a long period of time. Sometimes it's very sudden. And all of those things are things that gives us a clue to the potential cause of that. So, the causes we can put into 3 categories. The one is psychogenic. That means it's got to do with your psychological well-being. And there's psychological factors that can influence your erectile function. And it's not just saying it's in your head. No. There's actual factors that influence it on a physiological level. The second thing is organic causes, meaning disease. Things that is wrong there causing it. And then sometimes it can be a combination of both. So on this picture, that's not a technique that we use, but it's probably going to work. If it's a nice stormy day and there's some thunderbolt lightning outside, we can probably get it jump started. It's like a jumper cable. We put it up. Right. So what is some of the psychogenic causes that can be associated with it? Now, the one thing that you have to understand is stress, and it's probably one of the biggest erection killers. And the reason for that is that you have to understand, you may have heard, is when your body goes into a stress mode, there's a certain process that starts happening. We call it, the grand name was the sympathetic, we call it the fight and flight response. It is your body undergoes changes to get ready to fight or flight. That is stress. That is the physio. That is how you've been engineered. On a basic level, if you are getting stressed, your body needs to be either fight back or to run. And your body gets geared like that. Blood gets channeled to your muscles. Blood gets channeled to your brain. Blood gets taken away from your gut, from your penis, and all of that to be channeled to other places. That is how your body is engineered. That is how it works. So when you are stressed, trying to get an erection, which cannot really take place during a sympathetic overload, you're trying to go against what your body can do. So in a lot of instances, you have to address that first. And you'll see that a lot of, I don't know why this thing keeps doing on its own. Anyway, so things like relationship problems. Now, again, speaking from my perspective, which is that out of a Christian's perspective, my belief is that sexual intercourse and sex is something that God created to be within a committed relationship like marriage. And everything, the more I learn about sex and how it works, and the more I study it, the more I figure out the person or the Lord, the entity who designed this, designed it for it to be in a place like this. That's just how it's been designed. It's not been designed to be outside of this component. The main difference between sex or sexual intercourse in humans and in animals is that for animals it's procreation only. There is just too much interconnection with the brain and the psychological system and sex for it in humans to not just be procreation. There's a very deep and strong emotional component, psychological component to it that gets activated during sex. Neural pathways in the brain that gets activated, that form bondages, that form ties. That is how it's been designed in men. And if you practice this outside of what it's intended to do, then problems starts arising. Medical, physical, and emotional problems. And you can always draw it back to that. So stress, anxiety, relationship problems, the fear of failure, all those things are all things that can, depression is all things that can cause erectile dysfunction. So it needs to sometimes it's important to go have a look at identifying those potential causes before going on. What is one of the quickest ways to figure out whether your erectile dysfunction is actually because of disease and whether this is more psychological? And the interesting part is the key answer was Leonardo da Vinci's observation, and that is of erections during the night or in the early morning. Now, those erections that you don't have any control over, when you're sleeping or you are waking up and you think the dear Lord is playing a horrible trick on you because you have a full bladder and you need to pee, and how do you do this with something standing up like that? You stand like this, or trying to make calculations, or how am I going to get this in the toilet? No, that involuntary erection, we call it morning erections or involuntary erections, is actually outside of your control. And the interesting part of that, and I'll quickly tell you why you get erections in the morning, and that is actually to maintain your erection health. Because when you have an erection, blood flows into the penis. 200 to 300% more blood flows into the penis when you don't have, compared to when you don't have an erection. And that takes with it a lot of nutrients and oxygen and food to the very delicate structures without the penis and maintains it healthy. So that irrespective of your mood, irrespective of your relationship status, irrespective of anything else, you get at least daily or every second day, you get an erection to maintain the health of the penis. That is, again, how the Lord has wonderfully made you. So, the erection, morning erection, is to maintain erectile health. One of the first signs that you have organic pathology, meaning that you've got a disease that actually responsible for it, is that you start losing your regular morning or nocturnal evening erections. All right. So if you're not getting that erections anymore, then it's a good chance that there's underlying disease that is responsible for this. If you are having good erections during the night or in the morning, but when you have to have sex, you're not having it, there's a good chance this is psychological. It's got to do with stress, performance anxiety, all that. So that's a little quick tip of how to identify whether this is a real pathology or not, and that's where the morning erections comes in. So other causes, let's just go through what is the organic causes before we go to treatment. What is the other organic causes for you having erection? Now, it's very simple. The blood vessels is probably the most important part because blood flows into the penis when you get an erection, and there must be good open blood vessels. Now, the same diseases, the same problems that causes plaques and narrowing of the arteries, especially in the heart and in the legs, is the same things that causes plaque forming in the penis arteries. High blood pressure, blood sugar, high blood sugar, cholesterol, smoking, being overweight, those are all risk factors for developing erection problems. All right, so if you have problems with any of those, you need to control it really well, because if you don't control it, you will have narrowing of your blood vessels that goes to the penis, and blood won't be able to flow in there like it's supposed to. Other causes, and this comes in, is problems with your testosterone. So testosterone itself, except that the testosterone is probably the main driver for your sex drive, your wanting to have sex. We call it libido. That drive of wanting to have sex is driven by the hormone testosterone. So now we can think, if we have to remove testosterone from your body like we do with prostate cancer, a lot of instances, unfortunately, one can decrease sexual performance. One can decrease it. It is one of the side effects of this treatment. Okay. It's not that you will not be able to have an erection. There's medication that we can give, but your drive of wanting to have sex, unfortunately, goes down a bit if you remove testosterone. So one of the causes for erectile dysfunction is sometimes a decrease in your testosterone levels in the body. So sometimes we have to go check for that. One of the signs for that is that your wanting to have sex have decreased. Okay, and you feel, you sometimes pick up a lot of weight and you feel depressed and things like that. That can be due to decreased levels of testosterone in your body. Okay. Or sometimes you get those hot flushes the women always complain about. You know, when they get to a certain age, they start, so hot, and then it's so cold, and then it's so hot, and then it's so cold. Sometimes if your testosterone levels goes down, you can have similar symptoms like that. All right. So it is important, very important, erections. I always tell, now I know I know that in your church also smoking is not really encouraged, and it's good because one of the main causes of erectile dysfunction is smoking. I always tell, if you want to get men to stop smoking, you shouldn't put cancer on the box. You should say, you will have a slupful at age 50. Now, that will get guys to stop smoking. Yeah, definitely. 100%. I do both. At Tygerberg, I do both the erectile dysfunction clinic and I do the oncology clinic. I've gotten much more men to stop smoking at the erectile dysfunction clinic than at the oncology clinic. So I tell them, listen, it's either the erection or the smoke. Which one? Pick. You choose. Well, it's not both. All right. Okay, so what can we do? How can we treat this? So the wonderful thing is that over the past 20, 23 years, we've made a lot of advancements in managing erectile dysfunction. So there's literally no more, even if you've had operations done, even if you had treatment for cancer done that's caused your erectile dysfunction, there's no more reasons for you to have it because we've got treatment to get you having erections again. All right, so there is treatment for that. The most common treatment is tablets. You've maybe all heard about Viagra or certain similar types of tablets. Now, I'm not talking about Dragon Power and over-the-counter sachets that you buy at any Chinese shop. I'm not talking about that. I don't know what's in there. I can't vouch for anything. I don't know what they put in. Rhino horn, I don't know. Nail clippings, I don't know. But so what I can tell you about is actually the medication that's been studied and that works, and I'll tell you how it works. So our tablets that we usually prescribe, it's got a very specific action of work. And what it does, it actually opens up the blood vessels. It works on the blood vessels that goes to the penis. So sometimes if your blood vessels is a little bit narrowed, it will open up that blood vessels better so that the blood flow to the penis improves. And that it gets the erection strong again. The one thing that you have to understand, and that's why it's always important to get help for erectile dysfunction early rather than later. Remember I said that you have to have erections to maintain erections. If you've not had erections for a long time, you start having damage to the underlying structure in the penis that causes erections. The scar tissue starts to develop. If you for a long time have not had erections, that's the importance of the morning erection, so that you get the erections whether you want it or not. You get it to maintain the health of that penis. But if you don't have erections for a month, you already start having deterioration in the mechanism of having an erection. So either you use it or you lose it. That is the bottom line. So getting help for erectile dysfunction rather earlier than later. I have a lot of patients that say that they've not had erections for a year, and now they want treatment to restore things like they was with a tablet. I said, listen, we can try and get it to a point where you can have erections, but it's never going to be like it was beforehand, just because there's underlying damage that cannot be mitigated. So rather get help earlier than later. That's the key take-home from this. When you use tablets, and it's always sometimes to understand how you use these tablets, because I've also had patients that drink the tablets, now they can sit there in front of the TV and they wait for things to happen. Like nothing's working here. It doesn't work like that. You don't drink a tablet and Johnny wakes from the dead saluting. It doesn't work like that. So the erection or the tablets work that it potentiates the normal process. Meaning you have to still go through the normal process, and then the tablet, depending on what tablet is prescribed, what dosage is prescribed, it stays in the bloodstream from anything to 8 hours, and other tablets will stay in the bloodstream for about 36 hours. What that means is that during that time, you will be able to get a sufficient erection. Doesn't mean that you're going to walk around with an erection for 36 hours. That's also not supposed to happen. After you've ejaculated, then you need to have the penis go down again. All right. And then after, we call it a refractory period, where you can't get an erection again. And the older you get, the longer that period gets. When you're young, maybe that period is 20 minutes or 15 minutes, and then you can get it up again. That period, in elderly men can go up to 2, 3, 4 hours. All right. So after that refractory period is gone, you can maybe then have another erection while the tablet is still in the system. All right. Other options, so that's usually our first line of treatment, is to use that dosages. We will upscale the dose so it's a bit of a process. We have to play around with the dosages, the type of tablet, until we get a response that is adequate. So don't expect drinking 1 or 2 tablets and now everything is as it could be. It's a bit of a process of getting you there. But it's a route that you walk with your general practitioner or with your urologist. Other options, obviously, if this is a psychological thing, then the best place to get help for this is with some psychotherapy, with some counseling. That's important. If the problem is testosterone, then we sometimes have to supplement the testosterone, give you testosterone treatment. Unfortunately, if you've got advanced testis cancer, we can't give you testosterone because we've taken it away for a good reason. Then other options, especially in patients who are paraplegics or had previous surgery that can influence erections, similar to the prostate surgery that I've described. Sometimes it can influence your erections. And that's because of nerve damage to the penis. And if you have nerve damage to the penis, sometimes the best treatment is actually injections, small little injections that we give on the side of the penis to help you with erections. And it works very well. It's actually much less painful than you think. I know I could say, no. It's very, you can barely see the needle. It's a very small needle that we inject, very similar to the diabetics that have to inject themselves. They've got these little small needles, very similar, and that are usually very, very effective in patients that has had nerve damage. That's the way most of our paraplegic people do it. Then there's other things like vacuum devices that we can use. That's very effective. And then lastly, what I will show you, if all of these things fail, then there is surgical devices that we implant. Now this is the Mercedes-Benz of erection devices that we implant into the penis. This is erection on demand. It's got 2 cylinders that we implant inside the penis. We put it in with a little activation pump that we put there in the scrotum next to the testis. You can feel it there. And then a nice thing is, if you want erection, you just give it 3 or 4 pumps. Done. Your wife doesn't even have to wake you up. She can just pump it up. You teach her how to work it. And then you're ready. And when you finish, you press the button and it goes down again. Can't be easier. So very effective. This works really well. We do quite a number of them for patients. So yes, there is no more excuse. No more excuse. So I'm going to tell your lady, no more excuses. All right. Let's quickly talk about premature ejaculation. What is premature ejaculation? Premature ejaculation is a form of erectile dysfunction, but it is got to do with inability to delay ejaculation to sufficiently enjoy lovemaking. So you just come too quickly. That is what it's about. And it's a difficult thing because, again, I refuse to treat premature ejaculation outside of the context of a stable relationship. I do have a lot of patients that come to me and complain about this thing, and I'm saying, listen, but we cannot treat this outside of a stable relationship because there's so much other factors that influence this. I mean, to give you an idea, how does it manifest? It will be ejaculation that's too soon or very soon before the start of intercourse or just at the beginning of intercourse, or just ejaculation in the absence of sufficient erection. So you didn't get a proper erection and you already ejaculated. So what is too quick? Because this is, again, eye of the beholder. What is too quick? So it varies so much because in some people, 40 seconds is not too quick. And for other people, 10 minutes is too quick. So essentially what we say is that if you're going over 2 minutes, there's no problem with premature. Even if you feel you've got a problem, there's no problem. Below 2 minutes, we will start having a look if there's something that can be done. It's important to understand there's things that can cause this, and the majority of them has got to do with alcohol, recreational drugs, certain medication can play a role. The novelty of your partner or situation. That's why I don't treat this outside of a stable relationship, because if you've not had sex for 6 months, and now you have sex, you're going to have premature ejaculation. For that first or second, or even third, or even the fourth time, you're going to have premature ejaculation. That is just how it is. So outside of the context of having a stable relationship, we don't treat this. So there must first be a stable relationship, and then we can talk and try and sort this out. So we get different things where it's either lifelong, or it's situational, or it's acquired, and we try and figure out when we consult with you, where's the problem? Has this been a problem your whole life? Is it a new problem? Is it something that's just been there forever, or is it just in certain situations where this happened? Because all of that will help us to understand and give you the right treatment. Now, the majority of this you can manage without medication, just with some lifestyle or adjustments and things. Probably the first thing that I usually tell the guys is start using a condom, because a condom can just take a little bit, just numb the sensation a little bit, but enough for you to extend a sexual intercourse. So I usually say, let's start off with a condom, and the majority of time the condom is sufficient to sort this problem out. But there's other things that we use. Sometimes we give some local anesthetic, topical creams that they put on that just numbs it a little bit inside the condom. There's certain behavioral treatments that you can use. For example, at that point where you feel like you're going to ejaculate, you can put some pressure on the bottom part of your penis, the base of your penis. You can apply pressure there, and you will stop the ejaculation, or you will limit the ejaculation. And you keep the pressure there for about 20 to 30 seconds, and then you can continue again. So there's a lot of techniques that can be used, but your doctor, if your urologist, will be able to take you through these if that is an issue. Right. Last slide, and then we will do questions and answers. And this is a vasectomy. And obviously, the vasectomy is something that there's a lot of misperceptions about. Firstly, it's what we do. The vasectomy, remember that your semen does not come from your testis. Now, what is the semen? Is the fluid that comes out. That does not come from your testis. the sperm that is inside of the semen, but that only contributes about 0.5% of the volume of the semen. That comes from the testes. So that is the bullets that goes into the testes, into the semen. All right. So all that we do is we take the little pipe that goes from the testes. There's a little pipe that goes from your testes. It goes all the way up into your groin area. Then it goes into your pelvis, and then it goes all the way at the back, and it links up to the prostate, and it links up here. Most of your semen comes from the prostate and these little glands here, they're called the seminal vesicles that's sitting behind the bladder. Those are responsible for your semen. This just supplies the sperm cells that goes into the semen. So if we tie off these tubes, because what we do is we will cut these tubes, we'll make a little small incision here on the scrotum, literally like 1 centimeter. We make a 1 centimeter incision, we pull that tube out, we cut it in half, we tie it off, we put it back, we put 1 suture in. Done. So all that it does, it takes the bullet out of the semen. You still ejaculate, you still have the same volume of semen that you had prior to the vasectomy. The only thing is there's no bullets in the semen. All right. So it got no influence on your sexual function, none whatsoever. All right. The procedure takes about 20 minutes. Sometimes it's done under general anesthesia, but most of the time we can do it under local anesthesia. We give you a little small injection there, you don't feel anything, do it, and you walk out there, go home. Done. All right. So it's a very, if we have to compare this to, for example, a procedure to prevent pregnancy in females, this is much less invasive than the operation that you have to send your wife for us not to get children. So if we had to choose which one's got the less risk, it's probably you. Then vasectomy is much better to do. If you have to go tie off the tubes in a female, it's a much bigger operation than the one that we can do for you to get vasectomy done. So it is literally, we just interrupt that tube and we do it right here at the top part of the scrotum. 1 cut on this side, 1 cut on that side, and it's done. Right. That is my talk on the different topics. Now, you guys are welcome